So I want you to imagine two women picking up a hormone prescription at your local pharmacy.
Okay.
They're standing right next to each other in line. One is 55 years old and the other is 28.
Right.
And looking at them, you might assume, they're simply dealing with a similar biological hiccup. But the truth is, one of these women is just trying to cool down a hot flush, while the other is in this desperate race to save her bones and her heart from aging 30 years overnight.
Yeah, it's honestly one of the most profound contrasts in modern medicine because they might literally be holding the exact same type of medication in their hands.
Wow, really?
Oh, absolutely. But their clinical goals, the dosing math, and, well, the underlying biology are just worlds apart.
And that contrast is exactly our mission today. So welcome to the Deep Dive. We are taking a stack of medical guidelines, specifically reports from the British Menopause Society and the European Society of Human Reproduction and Embryology.
The BMS and HRT guidelines, yeah.
Exactly. And we're using them to explore how hormone replacement therapy, or HRT, completely flips its playbook, depending on the patient's age.
It really does.
We're looking specifically at that 55-year-old going through standard menopause versus that 28-year-old who has just been diagnosed with premature ovarian insufficiency, or POI, as we'll call it.
Right, which is a condition where the ovaries just start functioning normally before the age of 40.
Which, that fundamentally changes everything about her physiological landscape, right?
It changes everything. The central question these medical guidelines are grappling with is, how and why HRT dosing is managed so differently for a young woman with POI compared to a woman in her 50s.
Okay, let's unpack this. Because to understand how the prescription changes, we first have to understand the why. We have to look at the underlying goal of the treatment.
Exactly.
So let's start with the older woman. According to the guidelines, the usual age of menopause, which they abbreviate as UAM, it averages around 51 years old in the UK.
Yeah, 51 is the average.
So for a 55-year-old, what is the primary medical objective there?
The primary goal for her is symptom control. Pure and simple.
Okay.
When a woman reaches her 50s, her body is genetically programmed to shut down ovarian estrogen production. It's a completely natural transition.
Right, it's expected.
Exactly. But that transition causes immediate and often super severe discomfort. Hot flushes, night sweats, mood changes, and urogenital symptoms like vaginal dryness.
Got it.
So the doctor prescribes HRT to improve her quality of life right now. It's really just about mitigating the friction of a natural transition.
But reading through the guidelines for the 28-year-old with POI, I noticed the language shifts entirely.
It's a totally different tone.
Yeah, the word comfort practically disappears.
Mhm.
Instead, the guidelines stress that for a young woman missing out on decades of estrogen, this treatment is about primary prevention. It's about survival and long-term health.
Because a woman in her 20s or 30s who loses ovarian function, she is facing a massive, unnatural biological deficit. Estrogen isn't just a reproductive hormone. You have to think of estrogen as like the maintenance crew for the city infrastructure of your body.
Oh, like that.
Yeah, it keeps the blood vessels flexible, it communicates with the brain, and it regulates the cellular turnover in your mones.
So without it,
Without it, young women with POI are at a highly elevated risk for cardiovascular disease. They're at risk for cognitive impairment, even early onset dementia.
wow.
And they face this catastrophic loss of bone density, which leads to severe osteoporosis.
So to build on that city infrastructure analogy, it sounds like for the 55-year-old, the city is completely built, the maintenance crew retires, and maybe you get some annoying potholes.
Right, the hot flushes.
Exactly, those are the hot flushes. So you give her a low dose of HRT just to patch the potholes. But for the 28-year-old, her city is literally still under construction.
Yes.
If you fire the maintenance crew now, the half-built bridges are just going to collapse.
That is the exact biological reality. And to really understand that, you just look at the cells in the bones. Your bones are constantly being remodeled, right? You have cells called osteoclasts that dissolve old bone and osteoblasts that build new bone.
Okay, so a tear-down crew and a build-up crew.
Exactly. And estrogen's job is to keep those bone-clearing osteoclasts in check. A 28-year-old hasn't even reached her peak bone mass yet.
Oh, wow.
So if she loses estrogen, the osteoclasts just go into overdrive. They start clearing away bone before her structural foundation is even fully formed.
I'm struggling to understand something here, though. If estrogen is so incredibly vital for the heart and the bones, why are we okay letting the 55-year-old's foundation crumble on a low dose?
Good question.
Like, why not give her the massive dose to rebuild her infrastructure, too?
What's fascinating here is how the body's expectations change with age. The 55-year-old already has 35 years of estrogen-protected bone banked.
Ah, okay.
Her cardiovascular system matured fully under the protection of physiological estrogen levels, so her baseline risk is fundamentally different.
That makes sense.
Plus, her body's receptors have actually downregulated. They aren't looking for massive amounts of estrogen anymore. So those low doses of HRT that perfectly patch the potholes for an older woman,
Yeah.
they're entirely insufficient to keep the half-built bridges from collapsing in a young woman.
Which means the actual math of the prescription has to radically change.
Right.
Because the biological deficit is so much larger for the young woman, we're sort of moving from the why to the how much.
Right.
What are the actual numbers we are talking about here?
The contrast in the guidelines is pretty stark. Let's look at transdermal patches, which, deliver estrogen directly through the skin.
Okay.
For a 55-year-old dealing with standard menopause, symptom relief can usually be achieved with a low or medium dose. She might be prescribed a 25 to 50 microgram patch.
And that's enough?
Yeah, that is usually plenty to stop the night sweats and give her bones enough of a buffer during that specific stage of life.
But for the 28-year-old with POI, the guidelines state doctors must aim for physiological levels of estradiol. They basically have to artificially mimic a normal active menstrual cycle, right?
Exactly.
Because the sources mention aiming for serum blood levels of 200 to 400 picomoles per liter. And to hit that target, the young woman needs a 75 to 100 microgram patch.
Right.
That is double, sometimes triple, the dose the older woman is taking.
Or if we look at oral delivery, like taking a pill, she might need 2 to 4 milligrams of oral estradiol every single day, whereas the older woman might only need 1 milligram.
That is a massive difference.
It is. The young woman needs those massive physiological doses just to drag her system back up to a normal, age-appropriate baseline.
Here's where it gets really interesting, though.
Oh, yeah.
You cannot just pump triple the estrogen into a patient and call it a day.
Definitely not.
There's a biological counterbalance required. The sources call it the progestogen rule.
Yes, it's a vital safety mechanism because if a woman still has an intact uterus, giving her estrogen alone is incredibly dangerous.
Why is that?
Well, estrogen tells the lining of the uterus, the endometrium, to grow and thicken. So without a counterbalance, that unopposed estrogen will cause the lining to grow out of control.
Which leads to problems, I assume?
Big problems. It leads to a condition called endometrial hyperplasia, which is actually a precursor to uterine cancer.
Wow. So doctors add a second hormone, progestogen, to stabilize and eventually shed that lining.
Exactly.
But here is the logical hurdle I ran into. If we are pumping up the estrogen to these incredibly high physiological levels to save the young woman's bones, don't we have to aggressively increase the progestogen too?
You do, yeah. And this requires very careful medical management. The protection has to scale with the estrogen.
Right.
So if a woman is on a continuous regimen, meaning she takes the hormones every day without a break or brower, a standard dose of a progestogen, like northisterone, is 1 milligram.
Okay.
But if she is on those double or triple POI doses of estrogen, that 1 milligram of progestogen often needs to be doubled to 2 milligrams.
Oh.
Alternatively, the guidelines mention using 200 to 300 milligrams of micronized oral progesterone for a sequential regimen where she mimics a cycle. The biological rule is simple, really. The more estrogen you use to build the house, the more progestogen you need to secure the walls.
That makes perfect sense. And just to close the loop on how age dictates the delivery method, the sources point out this really fascinating physiological nuance for the older demographic.
Oh, the transdermal rule.
Yeah. The guidelines state that if a woman is initiating HRT, or continuing it, over the age of 60, doctors should avoid the oral pill entirely and prefer the transdermal root-so patches or gels. Why does a 60-year-old need a patch instead of a pill?
It all comes down to the liver, specifically something called the first-pass metabolism.
Okay, what is that?
Well, when you swallow an oral estrogen pill, it goes straight into your gut, and from there, it goes straight to the liver before it hits the rest of your body.
Right.
The liver processes the pill, but in doing so, it goes into a slight overdrive and actually produces extra coagulation proteins.
And coagulation means clotting.
Exactly. Those proteins slightly increase the risk of blood clots.
Ah. So for a 28-year-old with a pristine vascular system, that slight increase in clotting proteins is just negligible.
Totally negligible, yeah.
But for a 60-year-old whose blood vessels already have some age-related wear and tear, it becomes a real risk.
Precisely. By giving the 60-year-old a transdermal patch or gel, the estrogen absorbs through the fat and goes directly into the bloodstream.
So it completely skips the liver.
Right. It bypasses the liver's first-pass metabolism entirely, keeping the risk of blood clots virtually at zero. The delivery mechanism is literally adapted to the changing age of the patient's vascular system.
Amazing. So we have established that the young woman needs these massive physiological doses of hormones, carefully balanced with progestogen to protect her biological foundation.
Yes.
But we have to factor in her daily reality. I mean, a 55-year-old in the clinic might be primarily thinking about bone density, but a 28-year-old is heavily factoring in her social life, her relationship, and whether she might accidentally get pregnant.
Which introduces a major clinical dilemma in how we treat POI.
Because I found this statistic in the European Society of Human Reproduction and Embryology guidelines completely counterintuitive.
The pregnancy stat.
Yes. Having premature ovarian insufficiency, a condition where your ovaries have stopped functioning normally, does not mean you have a 0% chance of getting pregnant.
It is such a profound misconception. Many people hear ovarian insufficiency and they just assume it means permanent, irreversible menopause.
Right, that's what I...
But unless the POI was caused by, say, the surgical removal of the ovaries, the condition actually fluctuates.
Really?
Yeah, a young woman with POI still has intermittent ovarian activity. Her ovaries might lie dormant for months and then unexpectedly just release a viable egg.
Wow.
And because of that unpredictability, these women actually have a 5 to 10% chance of natural conception.
Which means if our 28-year-old doesn't want to get pregnant, she needs reliable contraception. But the dilemma is that standard HRT, even at those massive triple doses we talked about, does not provide contraception.
It doesn't. HRT is designed to replace the baseline hormones, but it does not consistently suppress ovulation the way birth control does. So the doctor and the patient hit this massive crossroads.
Right, because the guidelines explain that due to this contraception gap, many young women with POI are simply prescribed the combined oral contraceptive pill, the standard birth control pill.
Yeah, the COC.
It suppresses ovulation, solving the pregnancy worry, and it delivers estrogen and progestin. Plus, the sources specifically note that the birth control pill is peer-friendly.
And that matters so much. Think about the psychological weight of the diagnosis. A 20-something woman is basically told her reproductive system is failing.
That's heavy.
Super heavy. If she pulls out a packet of standard birth control pills at a cafe with her friends, no one blinks. It is completely normalized.
But HRT isn't.
No, pulling out menopause medication or having an estrogen patch visibly stuck to her abdomen marks her as different. It carries a really heavy psychological stigma.
I can totally see that.
Add in the fact that birth control is free or highly subsidized in a lot of countries, and it just becomes the default path of least resistance.
But wait, we just spent all this time detailing how a young woman needs natural, physiological levels of estradiol to literally rebuild her crumbling infrastructure.
We did.
Are the synthetic hormones in a standard birth control pill actually doing the same structural work as natural HRT?
That is the pivotal medical debate right now. The synthetic estrogens in the birth control pill, like ethinyl estradiol, they are structurally different.
Okay.
They bind to the body's receptors differently, and they are processed by the liver differently than the bioidentical natural estrogens used in modern HRT.
So they aren't equal.
Well, while the birth control pill does offer some structural protection, it is infinitely better than taking nothing at all. Emerging evidence suggests it falls short. Yeah, physiological HRT with natural estrogens appears to be significantly better at optimizing peak bone mass and improving cardiovascular risk markers in young women.
So the medical field suspects HRT is superior for long-term survival. But the patients prefer the birth control pill for the convenience and the contraception.
Exactly.
How are the guidelines resolving this?
By pushing for definitive data. The sources highlight an enormous ongoing clinical trial in the UK called the POI study.
POIs, right. Premature Ovarian Insufficiency Study of Effectiveness.
You got it. They're running a head-to-head comparison testing natural hormone therapy against the combined oral contraceptive pill.
Oh, brilliant.
Yeah, they are measuring the vital clinical outcomes, bone density, heart health, and blood pressure. The medical community is actively trying to prove that the continuous natural supplementation of HRT is the definitive winner, so they can basically change prescribing habits worldwide.
But until those results are published, the guidelines advise doctors to practice shared decision-making, right?
Yeah.
Like, if a young woman absolutely needs guaranteed contraception, or if the stigma of taking HRT means she just won't comply with the treatment, the birth control pill is an acceptable alternative. Adherence is everything.
Absolutely.
Because taking a slightly less optimal hormone is vastly better than leaving her bones totally unprotected.
100%.
Now, I know what is going through the minds of anyone listening right now. Every time you mention high-dose estrogen or triple the normal dose, people reflexively think of the scary headlines.
Oh, of course. The cancer fears.
Exactly. For decades, the media has battered us with warnings about HRT causing breast cancer and blood clots. We really have to dismantle this fear because the guidelines dedicate a significant amount of space to showing how a patient's age completely overwrites that risk profile.
Right. So what does this all mean for a 28-year-old? When people talk about those scary headlines, they are almost always referencing the Women's Health Initiative or the WHI study from the early 2000s.
I remember that being everywhere.
It was. And that study linked certain types of combined HRT to slight increases in breast cancer risks.
But how does a study showing cancer risk not apply to a young woman taking triple the dose? Explain the biological logic behind why those guidelines emphatically tell young women not to worry about the WHI data.
It's because of the difference between additive exposure and replacement exposure.
Okay, unpack that.
The Women's Health Initiative studied naturally menopausal women, mostly in their 60s. Those were women whose bodies had naturally shut down estrogen production. Giving them HRT meant giving them an additive exposure to estrogen that their bodies were no longer genetically expecting to have.
I see.
But our 28-year-old is entirely different. Her body is genetically programmed right down to the cellular level to expect high levels of circulating estrogen for the next 2 decades.
Right, because she's 28.
Exactly. So giving her physiological HRT isn't adding anything extra. It is simply replacing the exact baseline her DNA assumes is already there. Therefore, women under 40 using HRT do not have a higher incidence of breast cancer than the general healthy population.
In fact, the observational data in the sources shows something even more striking. POI patients on HRT actually have a lower risk of breast cancer compared to age-matched controls with normally functioning ovaries.
Because even when a young woman is taking those massive physiological doses of HRT, her overall lifetime exposure to circulating estrogens might still be slightly lower or simply more consistent and regulated than a woman experiencing natural, fluctuating menstrual cycles.
That is wild.
It really is. The fear of breast cancer is a fundamental biological misunderstanding when it's applied to POI. If a doctor withholds HRT from a young woman out of a misplaced fear of breast cancer, they are essentially subjecting her to a near certainty of cardiovascular and structural damage.
Okay, so the young woman starts her high-dose regimen. She understands it is replacing her baseline, saving her heart, and protecting her bones.
Yes.
She knows the breast cancer fears from the WHI study don't apply to her. Where's the finish line? Does she take this massive dose forever?
There are no arbitrary limits here. The golden rule established across all the sources, the British Menopause Society, the European guidelines, is that women with POI must be strongly encouraged to continue this physiological HRT at least until they reach the average age of natural menopause.
Which, as we established earlier, is around 51.
Exactly. She stays on that foundational high dose until she reaches the exact chronological age where her body would have naturally stopped producing estrogen anyway.
So what happens at age 51? Does she just stop cold turkey?
No, at 51, her medical journey simply merges with the 55-year-old we talked about at the very beginning. She transitions from the POI playbook to the standard menopause playbook.
Oh, I love how that comes full circle.
Yeah. At 51, she and her doctor will sit down, look at her current symptoms, check her bone density, and run a personalized risk-benefit assessment. They might lower the dose from 100 micrograms down to 50. They might adjust the progestogen. They manage her as a standard postmenopausal woman. But until she hits that natural age of 51, those physiological hormones are a non-negotiable requirement for her long-term survival.
So, to bring this all together for you listening, HRT is emphatically not a one-size-fits-all drug. You cannot look at a prescription pad and understand the medical journey without knowing the age of the patient holding it.
Absolutely not.
For a 50-year-old, HRT is a symptom relief tool, delivered transdermally to protect the liver and given at the lowest effective dose to ease a natural transition. But for a young woman with POI, it is essential, high-dose, life-protecting hormone replacement that is literally preventing her physiological foundation from collapsing.
If we connect this to the bigger picture, It highlights just how fundamental these hormones are to the very architecture of the human body. And the sources actually leave us with one final profound scenario that proves this better than anything else we've discussed to
Oh,
them.
this is the part of the guidelines that completely reframes everything. We've been talking about a 28-year-old losing her hormones. But what happens when POI strikes before a woman even reaches adulthood? What if the patient isn't 55 and isn't 28, but is a child?
Right. The guidelines have entire, highly specific protocols for girls with conditions like Turner syndrome or girls who are survivors of childhood cancers whose ovaries never functioned to begin with.
So what do they do?
If a girl hasn't naturally entered puberty by her early teens, doctors actually have to induce puberty using HRT.
They use HRT to build the entire biological system from scratch.
Yes, and the protocol is an incredibly delicate mimicry of nature. Starting around age 11 or 12, doctors introduce very, very low escalating doses of natural estradiol.
Okay.
They slowly increase the dose over 2 to 3 years. They are artificially recreating the natural onset of puberty to allow for proper bone acquisition, the development of the uterus, and cardiovascular maturation.
Wow.
And the guidelines explicitly state you cannot use the birth control pill for this process. It has to be natural estradiol to properly trigger the body's fundamental development.
It's incredible. We use the exact same hormone molecules to ease a 55-year-old's hot flushes, to save a 28-year-old's crumbling bones, and to physically help an 11-year-old grow into an adult.
It is a profound reminder of how deeply tied these exact same hormones are to our core development and survival as humans.
It really makes you think differently the next time you hear a sweeping generalization about hormone therapy. Remember that clinic waiting room? The prescriptions might look similar, but the foundation they are building couldn't be more different. Thank you for joining us on this deep dive. We'll catch you next time.